Welcome to AETCM, the emergency medicine channel.
Yes.
23-year-old female with no comorbidities presented to ER with alleged history of deliberate self-harm by taking 15 tablets of Metformin, 500 mg. So initial 10-second assessment, airway is patent with no gargling of secretion, hoarseness of voice or stridor, breathing, saturation of 98% with a respiratory rate of 18 per minute, bilateral air entry present, circulation wise BP of 110/70 with a pulse rate of 84 with S1 S2 heard, all peripheral pulses palpable. Disability GCS is 15/15 with a GRBS of 102. Exposure wise patient is afebrile. So it's adjoint to our primary survey. Since patient is taken Metformin 500 mg 15 tablet, we take a venous blood gas which doesn't show any acid base disorder or lactate is within normal limit, less than 2. CBC CRP.
What you're trying to tell?
Most common complication of metformin poisoning is or acute injection toxicity is lactic acidosis. What we should be expecting
that
is
can be
lactic
aggravated when there is any
underlying infection or acute liver failure, kidney failure, or any other comorbidities.
Renal or liver failure can aggravate the problem.
This is a case of 23-year-old with deliberate self-harm by intaking 15 tablets of 500 gram of metformin. Currently, patient is asymptomatic when patient was presented to ER within 1 hour of intake. After taking a thorough history and since patient is conscious oriented, we given a single dose of activated charcoal.
Single dose of how much?
50 gram of activated charcoal. Dosage of activated charcoal is 1 milligram per kg. 1 gram per kg, maximum of 50 gram.
Okay.
So we given 50 gram of activated charcoal by giving a nasogastric tube, and we admitted the patient for further evaluation and observation. So metformin is a primary biguanide which acts which is an anti-hyperglycemic agent which promotes euglycemia, and metformin alone won't cause hypoglycemia. But if the
theoretically it should never. But there are patients who come here with hypoglycemic episode on metformin. Theoretically it should not happen, but it happens in real life.
Acute toxicity, if the patient is having concurrent intake of other anti-diabetic drugs, where hypoglycemia can occur. So the mechanism of action is it decreases insulin resistance, decreases hepatic glucose output, and enhances peripheral glucose uptake, and enhances suppression of gluconeogenesis, and decreases glycogen stimulation and increase uptake of glucose by muscle and skeletal muscles and adipose tissue. So in net, it will help in decreasing fasting blood sugar and PPBS, then decreases HbA1c, decreases body weight, and decreases LDL and increases HDL. So this metformin is absorbed by the primarily by the upper part of intestine and eliminated unmetabolized by the kidneys. So in case of any kidney abnormality, so in case of AKI or CKD or a CLD or infection or any other comorbidities, or acute injection or overdosing can cause accumulation of metformin in the body, which most common major toxicity include lactic acidosis.
Okay.
So lactic acidosis is basically by
what are other drugs which can produce lactic acidosis?
Other drugs like salicylates. And then
when you present, you should also remember, no? HIV drugs, many of the HIV drugs can also produce lactic acidosis. There are a lot of drugs, I am not remembering that, but you should remember at least common drugs which are in practice.
Then this is mostly due to conversion of glucose to lactate, either accumulation of lactate and also by decreasing hepatic gluconeogenesis from the lactate. Mostly causes type 2 lactic acidosis, which can this type 2 metformin can also causes endogenous nitric oxide synthesis, causing vasodilatation, causing hypotension, which can indirectly causes type A lactic acidosis.
Type A also. So it produces both types.
Type A and type B. So clinical features mostly causes nausea, vomiting, abdominal pain. If there is lactic acidosis, they can cause physical examination, tachycardia, tachypnea, hypotension. In case of altered mental status, it's either due to agitation, confusion, lethargy, or due to hypoglycemia. So most common life-threatening toxicity include respiratory failure, modes for profound vasoplegic shock, and ventricular dysarrhythmias. Then metformin associated lactic acidosis is most common, like severe complication, either due to overdose or due to accumulation, and dehydration can also precipitate MALA. Symptoms usually start within 4 to 8 hours, and lactic acidosis may take even up to 12 hours to precipitate. So the criteria to say metformin associated lactic acidosis include lactate of more than 4 to 5 with a pH of less than 7.35, and sometimes in high creat may also seen. Degree of toxicity correlate with the serum levels and also pH levels. The lab investigations, we usually send blood glucose level as ABGs and BBG and serum lactate, CBC to rule out any infection that can contribute, and also anemia can also contribute lactic acidosis. Then RFT, LFT, and if there is any co-infections, cultures, urine analysis, X-ray, abdominal X-rays we have to do, and also look for any co-injections of paracetamol, salicylate, and ethanol. ECG also have to be taken to rule out any dysarrhythmias. Serum metformin.
Metformin as such will not
produce any dysarrhythmia. If in case of any co-injections, we have to look for dysarrhythmia. Serum metformin level is not that useful in diagnosis. Diagnosis mostly clinical. Treatment includes supportive treatment. If patient is not conscious oriented, we have to intubate the patient. This will be a physiologically difficult airway because because administration of any induction agent or nerve blocking agent can make the apneic phase of RSI intolerable and create a risk of circulatory collapse.
Okay.
Then we have to treat hypotension by first with fluids, and if it is not responding, we have to go for vasopressors. And hypoglycemia, if present, we have to treat with IV dextrose. In case of acute injection, if the patient is presented within 1 hour, we can give a single dose of 50 gram of activated charcoal. And the most common complication of activated charcoal is constipation. So we can also give sorbitol 1 to 2 milligram per kg, which is an osmotic agent which can increases the osmosis to the fluid and prevent constipation, and proper GI decontamination can be done. In case of profound acidosis, if the pH is less than 7.1 or if the pH is less than 7.2 in a severe AK, we can also administer bicarbonate 1 to 2 milligram IV push followed by infusion of 150 milliequivalents of 1 liter D5 water at infusion rate of 250 ml per hour in adults. This is administered to aim to maintain the pH to more than 7.1, or in case of AK more than 7.3. In case of persistent vasoplegic shock,
if you keep pH very low, what will happen to the patient?
Metabolic acidosis can cause patient can go into cardiac
failure
and cardiac arrest. So, if the patient is with a vasoplegic shock, that is persistent hypotension, despite adequate IV fluids and vasopressor therapy, we can also start on methylene blue 1 to 2 milligram per kg IV, up to 6 milligram per kg we can give. This act by decreasing nitric oxide mediated vasodilatation by inhibiting guanine cyclase and the nitric oxide synthase. This can be used in case of refractory shock. If the patient is having profound acidosis, that is if pH is less than 7.1, lactate is more than 15, with failure to improve within 2 to 4 hours despite adequate supportive therapy or presence of comorbid condition like shock, kidney impairment, liver failure or decreased level of consciousness, we can initiate the patient on hemodialysis. In case of persistent hypotension also, we can initiate the patient on hemodialysis. Hemodialysis can be discontinued when the lactate level is less than 3 and pH is more than 7.35. So in case of hemodynamically unstable patient, we can also start on continuous veno-vagal hemofiltration or CERT. So in case of disposition of patient, in case of acute injection, we have to observe the patient to 6 to 8 hours. If patient is asymptomatic with normal acid-base disorder, lactate is also stable after 6 to 8 hours, we can discharge the patient. If the patient are only having a mild lactate elevation, otherwise normal, we will advise the patient to stop metformin and see a primary physician after few days or if symptoms persist. But if the patient is symptomatic with the lactic acidosis and early features of lactic acidosis metformin associated lactic acidosis, we have to admit the patient and observe, and if patient worsens, we have to start on HD.
So here what happened to the patient?
Patient took 15 milligram of 500 or 15 tablets, so only 7.5 gram, which is not toxic dose. Toxic dose is more than
toxic dose or lethal dose?
Lethal dose. Lethal dose is more than 10 gram, but in children, if it is more than 1 to 2 tablets, like it's more than 1.7 gram also, it can be toxic to that.
So nothing required.
For this patient, nothing to be done, sir. Everything seems to be normal and
Glucagon?
we discharge the patient.
Suppose these patients are co-ingested with glimepiride, glipizide, glibenclamide. They all produce severe hypoglycemia. They may not respond to your routine treatment. So
glucagon can be given.
Glucagon can be tried in acute settings in that type of patients. Normally it will not produce hypoglycemia, but rarely some patients come with metformin induced hypoglycemia. Okay. Thank you.